Hello everybody, my name is Bradley Smedley, and I'm a third-year community college student at Cabrillo College in Santa Cruz, California. I'm working towards my associate degree in biology before I transfer, and today I'll be sharing what I've learned about hepatitis C care among incarcerated populations. So this summer I've had the privilege of interning with the Sage Center of Health and Justice at Yale. My PI is Emily Wang, and she is the founding director of the Sage Center and also a professor of medicine at Yale. Janaris was my mentor, and he is the program manager and associate director and a data analyst at the Sage Center. I just want to start by touching on some background information. My father was incarcerated when I was 6 years old, and he remained in prison for 18 years, where he was finally released 2 years ago. But during his incarceration, he used drugs and ultimately contracted hepatitis C while in prison. He wasn't able to access testing or treatment while incarcerated, and it wasn't until he was released that he was finally able to get tested and treated. Unfortunately, because he lived with hepatitis C for so long while he was in prison, his liver got diseased and progressed to stage 3 liver failure, and he was told without a liver transplant he'd have a maximum of 5 years to live. This personally really angered me because I waited my whole life to finally get to build a relationship with him. But I guess 5 years is better than nothing. And when I arrived here at Yale, Emily and Janaris gave me the opportunity to work on whichever project I found most interesting. And at that point, hepatitis C wasn't in the cards because the project was brand new and it was still in its infancy. But after I shared my father's story with a Sage employee named Alana, she mentioned to me that hepatitis C project was just getting started, and she suggested that I look into it. And I spent some time thinking about it, and I came to the conclusion that if I could leave this summer with a better understanding of how the correctional system failed my father, I would be extremely grateful. And that's exactly what I got from this experience. And I have a better understanding of how hepatitis C works in the United States of America and throughout the correctional system. And that's exactly what I'm going to walk you guys through today. So before we get to the nitty-gritty, I want to first cover what is hepatitis C. Hepa refers to the liver, and itis means disease, or inflammation. So hepatitis quite literally means inflammation of the liver. Throughout this presentation, you might hear me refer to hepatitis C as HCV, which just stands for hepatitis C virus. So HCV is a virus that lives in your liver and uses our own liver's proteins and enzymes to replicate itself. And once it enters our bodies try to fight off the virus by attacking the infected liver cells, and over time that repeat attack and heal creates scar tissue. Years of the scarring can build up on the liver, a condition we know as cirrhosis, and to the point where our livers no longer function. So now I'm going to walk you guys through a concept map I built to show you what hepatitis C looks like a little bit more in depth. So we're going to start with HCV in the United States, defined as simply a liver virus. And good news is we have a cure, direct-acting antivirals, or DAAs. The cost is about $20,000 per treatment per person, and it takes on average 8 to 12 weeks to complete the treatment. On the population side, or roughly 1% of Americans, or 2.4 million, are currently living with hepatitis C. How is it contracted? It's contracted through blood-to-blood transmission, through sexual intercourse, shared nail clippers, razors, needles, mother-to-child transmission, or before 1992, we didn't screen blood supplies, which consequently allowed HCV to spread through blood transfusions and organ transplants. So who's most at risk? Oops. Opiate use disorder, substance use disorder, injection use disorder, anyone sharing needles or drugs are most at risk. And in terms of symptoms, some people within the first 2 to 12 weeks experience acute symptoms like fatigue, jaundice, muscle pain, joint pain, dark urine. But a lot of people skip straight to the chronic symptoms instead, like easily bruising, weight loss, confusion, drowsiness. And this can go on for 10 to 40 years as a silent battle within your liver before someone even realizes that something's wrong. And if it's left untreated, it can lead to death. General population sees about 1.3 deaths per 100,000, and in the state prison population, that number more than doubles, with 10 deaths per 100,000. This gap right there is exactly why this population deserves a closer look. So again, why focus specifically on incarcerated populations? Well, the numbers make their case. HCV seroprevalence, meaning the detectable levels of HCV in your blood, is 13 times higher in a correctional system setting than in the general population. And incarcerated people account for roughly 30% of the entire US Hep C problem in the United States, despite being a small fraction of the overall population, and yet only 33 states are currently offering opt-out screening. So we have a population that's disproportionately affected, moving through a system that in 17 states isn't even set up to catch it. So this next concept map shows you exactly what happens or doesn't happen when someone enters the correctional system. I want us to say up front that this is heavily simplified, just to give you guys a general understanding of what it looks like. So we're going to start with HCV in the United States flowing into the correctional systems. And from there, ideally, everyone loops into the opt-out testing, meaning everyone is routinely informed they'll be tested unless they choose to decline. And right now, only 66% of states offer routine opt-out testing. And for that 66%, the path is testing leads to diagnosis, positive diagnosis leads to treatment, which takes 8 to 12 weeks, and full treatment leads to being cured, which means having a sustained viral response, which means the hepatitis virus remains undetectable in someone's blood after the treatment's completed. And let me specify that the virus might be undetectable after the medication ends, but that doesn't mean they're cured. Cured is when HCV RNA blood test remains undetectable 12 weeks after having the very last medication. Okay. And then after this, they eventually get released back into the general population and ideally transition into the transition clinic network. I've highlighted this pathway in gold because it's the ideal path we want everyone to follow. And now on this road, it's possible you get diagnosed with HCV and not meet all the stipulations to receive treatment. For example, your jail sentence isn't longer than the length needed to complete the treatment, which would be this map here, this road. So now let's talk about the larger group, which is, this group right here is if you don't meet all the stipulations, like the 1 year in, if you don't have enough time in jail to receive the treatment, that's actually that path. Let's look at the larger group now. 34% of states don't offer routine opt-out testing. Without testing, there's no diagnosis, which means there's no treatment, and people are released back into the general population and don't get the chance to find out if they are sick or not. And they often won't be referred to the transition clinic network post-release either, and this matters beyond the individual too, since roughly 2/3 of people released from incarceration within a 3-year period are reincarcerated. And that gap in testing follows them right back into the system and back on through the cycle all over again. So from everything I just walked you through, I want to simplify it a little bit further down to 3 major steps. Step 1 is screening and diagnosis. Step 2 is treatment and confirmed cure. And step 3 is continuity of care after release. I personally picked only one of these to dive deeper on because each one is its own research problem. For the sake of time, So step 3, continuity of care, is the one that most interests me. And I think step 3 is where the whole cascade collapses the hardest. Someone can be tested, they can be diagnosed, they can receive treatment while in custody, but the second they walk out the door, they have the chance of losing that all. So let's talk about what's actually happening at release. Even in the best documented programs in the country, we still see this drop-off. Connecticut, which is one of the most complete HCV care cascades out of any correctional system in the country, only got 63% of their people with chronic hepatitis C started on treatment. And only half of those had confirmed cure data available afterwards. So even in a strong system, release is where things start to fall apart. And here's what's already being done. Discharge referrals, appointment scheduling, Medicaid reactivation, transition care and patient navigation, and then here's what's still missing. A reliable warm handoff between jail and staff and community providers, integration with substance use and mental health care, basic logistical support like transportation, phone access, housing, social support, and follow-up all the way through the HCV cure test, and actually confirm whether someone stays cured after release. And that last point is a gap I saw across almost every paper I read. No one is consistently tracking whether people actually get confirmed cured after they leave custody. Given that gap, here's what I'd recommend as a next step: a study that directly compares outcomes for people who are released through a structured transition of care model versus those who would receive a standard discharge referral. Specifically, we would compare linkage to care rates and confirmed HCV cure rates. In simpler terms, we're asking, does actively helping someone transition into a community healthcare actually help them or increase their likelihood of seeing a provider, completing treatment, and being cured of hepatitis C? And a structured model could include scheduling appointments before release, or transferring medical records, helping with insurance, medications, and that would be compared with the standard approach, where a person may simply just be given a referral or a phone number or just their discharge paperwork and then be expected to just navigate the healthcare system all on their own. And this is where the Transition Clinics Network really comes in. TCN was created to address this exact problem. It builds community-based, patient-centered healthcare for people returning from incarceration by connecting them to primary care, behavioral health care, and social services, with a particular focus on people managing chronic health conditions. A major part of this model is hiring community health workers, often people who have experienced incarceration themselves, and integrating them into the medical team. These workers help patients navigate medical care, insurance, medications, transportation, and other social services. TCN also partners with community organizations, correctional systems, and government agencies to create more of a coordinated transition from incarceration back into the community. So this summer I've had the chance to shadow a TCN clinic here in New Haven firsthand, and seeing the direct impact it had on other people's lives really inspired me. For example, watching the way individuals' faces would light up when Manya, our community health worker I shadowed, would walk into the room was just incredible. She had an infectious personality and a positive outlook on life, and that was just very inspirational and undeniable to me. And that's exactly why the community health worker aspect of the TCN approach is the entire key to making this approach as successful as it is. So I just want to close by talking about how I'm planning to get involved with the TCN network when I get back to my own community. Janaris and Emily are lining me up with one of the closest locations to me, which is in San Francisco, which ironically is the first TCN location ever opened by Emily Wing. My plan is to transfer to UC Berkeley as my first choice, and if I don't get accepted to Berkeley, then I'm going to go to Davis, which I've already gotten accepted into. And regardless of wherever I go, I'm going to continue volunteering at a TCN location closest to me. I want to just get back in any way I can, whatever that looks like, to doing paperwork or maybe even becoming a community health worker myself. And I'm excited to get involved and just get back in any way. Yes. And a special shout out to my mentor Janaris for being such an amazing mentor and never making any question I ask feel too little or too uneducated to ask, and just making me feel worthy of being here at Yale. My biggest takeaway is the foundation of skills and experience I'm walking away with, and skills I'm going to carry into my next research internship. So thank you so much. Questions?